Good afternoon. I'm Jane Barrow, Associate Dean for Global and Community Health and Executive Director of the Harvard School of Dental Medicine Initiative to Integrate Oral Health in Medicine. I'd like to welcome everyone to today's webinar, Access to Dental Care. How is COVID-19 increasing disparities? We have a terrific panel for you today, all of which will be moderated by Dr. Sheenam Taku. Dr. Taku is an instructor in the Department of Oral Health Policy and Epidemiology at HSDM. She conducts research on behalf of the initiative, specifically stakeholder analysis, collaboration with advocacy groups, and investigating new modes of oral health delivery. She is also an investigator in the HRSA-funded center, CIPCO, the Center for the Integration of Primary Care and Oral Health, a national center which is funded as an academic unit for the integration of primary care. Her research focus is the integration of oral health competencies with primary care training, and specifically behavioral health and social determinants of health in dental education and practice. And with that, I'd like to turn it over to Dr. Taku.
Thank you, Dean Barrow, for the introduction, and we welcome everyone to discuss how the COVID-19 pandemic is increasing disparities in access to dental services. Before I introduce our fantastic panel for today, I would like to outline some housekeeping rules. Today's webinar will feature 45 minutes of presentation and discussion with our panelists, and we will use approximately 10 minutes towards the end so that our panelists can answer questions from the audience. We ask that you submit your questions using the Q&A function on your screens. My colleague, Christina Cassano, will help me collate the questions and present them to our panelists. We are recording this webinar. In the coming weeks, we will post a recording of the webinar on the HSDM Initiative to Integrate Oral Health in Medicine website. I am very excited to discuss this topic with our esteemed panel today. We are joined by Ms. Cheryl Fish Parcham. Ms. Fish Parcham is the Director of Access Initiatives at Families USA. In this role, she focuses on public policies that would improve access to coverage and care, including those related to oral health and to behavioral health services. Thank you, Ms. Fish Parcham, for joining us. Our second panelist is Rear Admiral Timothy Ricks. Dr. Ricks serves as the 19th Chief Dental Officer of the U.S. Public Health Service and as Assistant Surgeon General. In this role, he advises the Surgeon General on oral health issues, interacts with federal and state agencies, interacts with dental and public health organizations, and with chief dental officers from other countries. He also chairs the HHS Oral Health Coordinating Committee. Thank you, Admiral Ricks, for joining us today. Our third panelist is Dr. Bob Russell. Dr. Russell is the State Public Health Dental Director and the Bureau Chief Oral and Health Delivery Systems at the Iowa Department of Public Health. Thank you, Dr. Russell. And our fourth panelist is Dr. Brian Swann. Dr. Swann is Chief of Oral Health Services for the Cambridge Health Alliance, where he practices clinical dentistry and conducts the oral physician program within the general practice residency program. He's also an assistant professor of oral health policy and epidemiology at the Harvard School of Dental Medicine. Thank you so much, Dr. Swann, and the whole panel for joining us today in this very important discussion. As you can see on the screens, a recent study conducted by the Commonwealth Fund when comparing adults across 11 high-income countries found that income-related barriers and access to health during the pandemic were greatest in the US. Throughout the 9 months, we have seen multiple such studies and news publications pointing to how the COVID-19 pandemic has disproportionately affected vulnerable populations, especially communities of color. Black persons are 13% of the US population, but account for more than 22% of COVID-19 deaths. Hispanic persons are almost 33% of new cases nationwide. Moreover, the burden of the economic downturn due to the pandemic has also been disproportionately borne by these communities. Thinking specifically about dental care, we also know that persistent barriers to care and disparities in access to dental care exist among these very same vulnerable communities. So what are the implications of that? And for that, I want to turn to Admiral Ricks. I would like to start with you. Can you outline, and I'll stop sharing. Can you outline for us what these disparities look like and how might the COVID-19 pandemic make them worse?
Thank you, Dr. Tiku and Ms. Barrow and Harvard for highlighting this issue. I'll give a brief overview and then I'll turn it over to my fellow panelists. And so I want to start off by talking about access to care in general in the US. And this graph on the right shows our access to dental care across the US since 1996. And this is from the Medical Expenditure Panel Survey. And you can see that the highest we've really ever achieved was 45% back in 2003. And our Healthy People goal, which is a set of national priorities to improve the overall health and well-being of Americans, our Healthy People 2020 goal, which is in the red dotted line, was set at 49%, and we really never got close to that. Our Healthy People 2030 goal is much less. It's going to be around 45%, which, as I mentioned, we've achieved once. But our most recent data show that only 43.3% of Americans access dental services each year. And we know that there are some significant barriers. There are social determinants of health, such as food insecurity, housing insecurity. There's the cost of dental care. There's oral health literacy of the population. There's the cost of dental education, which drives where the workforce sets up practice. And there are other workforce issues as well, scopes of practice and things of that nature. I want to draw your attention to some inequities that we see in oral health related to race, ethnicity, and income. So let's first talk about race and ethnicity. If you look at, and this is from a 2019 CDC report, but if you look at Black non-Hispanic Americans and Mexican Americans and compare them to white non-Hispanic Americans, especially in children, but also in older adults as well, across multiple conditions, untreated tooth decay, caries experience, tooth loss, and so forth, you'll see that Black non-Hispanic Americans and Mexican Americans suffer disproportionately from oral disease. And in fact, in some cases, 2 to 3 times the prevalence of disease as white non-Hispanic Americans. If we look at income, those that are living at or below 200% of the federal poverty level, that's what FPL is, which is currently around $25,000 for a family of 4, they also suffer disproportionately when compared to those who are living at or above 200% of the federal poverty level, with 2 to 3 times the disease prevalence as the middle class. Across the US, there are dental deserts. There are dental deserts in rural America. There are dental deserts in metropolitan areas. The Health Resources and Services Administration, or HRSA, designates health professional shortage areas in primary care, mental health, and oral health. And in relation to oral health, we know that there are 60 million people, as indicated in the gray shaded areas, that live in dental health professional shortage areas. There are almost 6,500 of these dental HPSAs. And HRSA estimates that would take almost 11,000 oral health professionals to go out to these areas to fill those voids. In rural America, especially, what we see is some significant barriers. We see 9.5% less access to dental care compared to the urban areas. We see children with 5% less likely to have access to necessary preventive dental services. We see adults with 7% more missing teeth, and 4% are more likely to have complete edentulation. And even in older adults, rural seniors have visited the dentist less often than their urban counterparts. Now, with relation to COVID-19, what we know before COVID was that many people that sought care for dental conditions in the emergency departments across our country were either uninsured or underinsured. These data here are from the Agency for Healthcare Research and Quality, and I've highlighted on the left pie graph that 40% of those who presented to the emergency department with dental conditions were uninsured, 30% had Medicaid. And the significance of this is that one patient every 14 seconds presents to an emergency department with a dental condition. And $2.4 billion is spent each year on dental care in emergency departments, 70% of which is outside of normal business hours, normal dental practice business hours. So the big question that I can't answer right now is what happened when COVID-19 happened and patient and emergency departments started shutting down care for non-COVID types of services. Where did these patients go? One thing we did see is with relation to Medicaid dental services, we saw a significant drop in Medicaid dental services for children. And this is from the Centers for Medicare and Medicaid Dental Services. And if you follow the top three wavy lines, those are from 2017, 2018, and 2019. And those are the services by month for Medicaid and CHIP beneficiaries 18 years and younger. And you see on average, there are 3.5 to 4 million services per month. When dental practices started shutting down in mid-March, you see this huge drop. There was actually almost a 70% drop in the number of services to less than 500,000 by April. Now it started to rebound in our latest data to May, and you can see that it did rebound as clinics and practices across the nation started reopening. We don't have more recent data at this point. We also know from the American Dental Association Health Policy Institute that dental practices really across the country really have not returned to normal, despite all the infection control implementations that have been made. We see that less than half of practices have resumed to normal operations as defined by patient volumes at or above their pre-COVID levels. So I hope that this sets the stage for my fellow panelists to talk more specifically about oral health inequities in the age of COVID-19. So at this point, Dr. Taku, I'll turn it back over to you. Thank you very much.
Thank you so much, Admiral Rix, for outlining the various inequities, especially in populations, vulnerable populations seeking dental care. The last two slides were very interesting, and you mentioned decrease in dental service rates among Medicaid children in particular. Ms. Fish Parcham, can you walk us through some of the ramifications of the pandemic and the subsequent economic downturn on these Medicaid beneficiaries?
Sure, and it's really important to think about Medicaid beneficiaries right now because there are actually things that people can call on policymakers to do to help with these problems. First, just to start off, I want to kind of ground us in how many people have lost coverage altogether during this pandemic, that about 5.4 million workers have lost health insurance between February and May alone. And the coverage losses were twice as high for African Americans as for whites. So this is really taking a disproportionate impact on communities of color. And though we don't know how many of those people lost dental coverage, we know dental coverage is not as good as other coverage. We can assume that about half of workers with employer-sponsored plans had dental benefits before, and so that loss was great. And as they lost income, they also couldn't afford out-of-pocket dental care. And Dr. Ricks talked about emergency departments as a last resort for treatment of oral pain. And with emergency departments beyond capacity, we can only guess that that has taken its toll. We also know that hospitals have closed in some rural communities, so dental deserts are probably getting even worse. Adults' access to Medicaid coverage has always been problematic. You'll see on the left the states that have expanded Medicaid coverage to pay.
Sorry, Ms. Fish Parcham, we can't see your slides if you would like to share.
Oh, I'm sorry.
That's fine.
That's.
That's fine, or we can have, oh, great.
Oops. Okay, can you see now?
Yes, you just have to slide share. And we'll be.
I'm sorry, can you see this? Is it shared at the moment?
No, we can also have, Christina, could you help us with this?
Let me know when you can see it. I seem to be seeing
we can actually see your slides. We just can see the entire show. So if we could go to the slideshow.
I'm sorry. Are you?
If you actually just click twice on the slide and go to.
Are you seeing it now?
So.
Do you see it now?
Why don't I share the slides and you can tell me how to.
Okay, that would be great.
Yeah, I can do that. Sorry.
Are you? I can't see now. Do you have them shared yet?
Yeah, I'm just doing that now.
Okay.
Yeah.
Okay, if you can go to the third slide, please. Great. Let's one back one, please. There we go. So on the left, you'll see the states that did and didn't expand Medicaid. And so all the orange states don't provide any Medicaid benefit to adults that don't have children or that are low income, very low income. On the right are the states that provide oral health coverage for adults through their Medicaid program. So the orange-ish states are states that are only providing emergency services and not full dental care to adults. So there are real disparities there as well. Next slide, please. We know that Medicaid policy makes a tremendous difference to how people experience care, and you'll see on the left the how disparities have been affected by whether Medicaid is expanded or not. The Hispanic adults that in expansion states, their uninsurance rates went way down, as did Blacks, even more so than whites as states expanded. And on the right, you'll see that they also in expansion states, the share of adults getting medical care greatly improved as states expanded generally. And we can only guess that if the state also elected to provide dental care, that the situation improved as well. Next slide, please. So this slide is about people who are duly eligible for both Medicare and Medicaid by race. And so these are seniors and people with disabilities who are in the low income community. And you'll see that African Americans and Hispanics and other ethnic groups make up a bigger share of that population than would be indicated according to their percentage of the population that they actually are. So if we can expand Medicare and with it expand coverage to duly eligible beneficiaries, we'll be making a big difference to whether people can get dental care. So let's go to the next slide. The thing that's going on right now is that the COVID relief package initially has extended federal medical assistance by increasing the matching rate for Medicaid and by requiring that states preserve Medicaid eligibility and benefits. But that policy changed November 2nd, and it's really important that people comment during the comment period. What changed is that states are now allowed to cut benefits even during this pandemic. And we know that before the guidance that required them to continue Medicaid benefits earlier this year, that 3 states were prepared to cut Medicaid benefits to adults, Nevada, Colorado, and California, and that more will, without a requirement to maintain benefits during the pandemic, many more states are likely to cut benefits. There are immediate opportunities to do something about this. You can submit comments on the federal rule before January 4th. You can talk to the Biden and transition team and the administration and ask them to rescind that guidance. You can talk to members of Congress and tell them how important it is that this increased matching funds from Medicaid be included in federal relief packages. And you can watch state budget processes and engage state legislators and governors about what they'll do with their Medicaid budgets in the months to come. Next slide. We know that cuts have long-term consequences, and that in California, when there were cuts in 2008, by 2018, utilization had not come back. It takes a lot to get utilization back, and so that's why it's important to maintain Medicaid benefits. Next slide. And we know that coverage is a first step, but people also need transportation, accommodations, translation, maps of where there are open practices, and all of these things have been problematic during the pandemic. A local community clinic tells us that getting vans to pick up people to go to dental appointments has been a real barrier for them during this pandemic, that they can't do that. Advocates in California say that though the state tried to provide maps of open practices, they haven't kept the maps up to date, and so people are not able to figure out where they can go for dental care. So keeping these kinds of services in place is also very important. Next slide. And finally, this is about how many people of color go without dental visits in Medicare, and that is because Medicare doesn't cover dental care, and especially low-income Medicare beneficiaries, who are really a huge proportion of the population, are going without dental care. So Medicare policy will make a big difference to older adults and people with disabilities. And there was legislation introduced this past Congress to do that, to cover adults with Medicare benefits in dental care, and that's something that we would also very much support. Thank you.
Thank you so much, Ms. Fish Parcham. And I wanted to point out that, consistent with data that you presented on reduction in uninsurance rates in states that have expanded Medicaid, a recent study actually by Dr. Ilani that was published in Health Affairs also finds that non-whites had greater gains in Medicaid dental coverage in Medicaid expansion states. So this underlies, obviously, the importance of this program for communities of color. Dr. Russell, I want to turn to you. And what are some of the challenges that are being faced by state Medicaid programs? And in addition, I want to look at the supply side of this. There are data that was mentioned from ADA Health Policy Institute on private practices and the losses suffered throughout the pandemic. How has the pandemic affected safety net dental settings?
Background I've chosen for you today is fire, and that's appropriate because that's exactly what we're facing. As I get ready for my slides here, let's see. Okay, So we're going to start with what the other two speakers, panelists have already kind of presented. Just give you a little background here that nearly 4 in 10 Blacks and Latino adults reside in one of the 14 states where Medicaid adult dental benefits cover no services or emergency only. So that's the general background even before COVID started. So what's happened since then? There are a lot of concerns among those populations. For example, untreated tooth decay. Many Blacks continue to experience higher levels of untreated tooth decay as compared to non-Blacks. There's also a problem with the fact that delayed opening in schools during the COVID period has even made access even more trickier for those at-risk populations. And some patients simply, Black and Latino communities with high infection rates are anxious about going back to the dentist, especially given the risk factors that they have learned that dental practices have. Even though many dental practices have made accommodations, have made corrections to those situations, there's still a bit of a cautiousness among populations. And I want to talk about my state for a moment. And this is among the states that I work with and other states, dental directors, I find that many of their experiences are very common to what we're experiencing. Let's start with the fact that this is in 2019. And we can say that in 2019, in our state fiscal year, we have, this is ages 6 to 12, 61.2% of our Medicaid enrolled children were getting a dental visit. Now, if we take that to current, we're seeing about 55% getting some level of access to care. And so you can see already we're suffering a reduction in the number of kids that are being served. And this is through July of 2020. So, and that continues to exist to this day. Now, what does that turn into? For example, and this is between 2019, the months of the 8th month to the 11th month, you can see here that kids screened were 5,371. The kids that received dental sealants were about 2,264, and that's within that several month period. Now look at the same indicator for the year 2020 in comparison. And you can see the numbers have dropped significantly. 1,305 kids screened, 659 kids sealed. And a lot of this is due to the fact that many schools are not accessible to dental programs actually seeing children. Some children are at home because of the COVID risk factor. And some schools are venturing to be open. So we do see some access, but this has definitely decreased access in our state. And so I want to just show a little bit about how does that work as far as our racial breakouts. For example, among the white populations, this is 2019 data, 81.5% were getting access to care. And that's roughly about 4,376 in our state. And that's of those eligible on Medicaid. And this is in our school screening program. So keep in mind, this is not the total Medicaid population, but it's definitely a section of that population. And it's what work we do in our screens. We have 99 counties, and of those 99 counties, we have school screening programs in each. And you can see the African-American population made up about 6.7%. We can also see that other in our unknown populations, 5.1, and multiracial. That's how it breaks down in our state. Now I want to show you what that looks like today. So in 2020, whites actually increased the number of those being seen in school-based settings, such as they're now representing up to 86.1%. So they've moved up a whole 5%. But look what's happening in the racial categories, which have dropped. Black Americans are now 2.1. Asians 1.9. You can see here multiracial 2.3 and unknown 5.1. And so I just want to recall, going back to the slide I showed before, Black Americans was 6.7, unknown was 5.1, and multiracial was 4.0. So just to be aware, those numbers are significantly lower as far as representation in this total population. So we are experiencing decline among certain populations, but primarily minority populations. So as we turn our focus to the health centers, I want to make one thing very clear. Health centers never had the capacity of meeting all the oral health needs of our populations. That just technically was not possible. One of the reasons is because health centers make up about 22.6% as far as dental capacity in a health center compared to their medical capacity. So in other words, health centers are primarily primary care medical facilities. Those that do have dental only makes up 22.6%. And of all the medical users inside a health FQHC, only 26.9% could access dental care under the best conditions. So just be aware, health centers could never meet all the needs of their current medical population, not to mention those outside. So that brings us to this diagram I'd like to talk about a little bit. Let's talk about before COVID. What were the situations affecting health centers and on average? I already mentioned that typically they can only accommodate 20% of the overall health center's capacity. So I already mentioned that. Dental appointments vary. Unlike medical appointments, which tend to fall within more predictable time frames, dental appointments can last from 30 to 90 minutes or even longer for certain surgical cases. The average cost per visit, and this is 2018 data, is $190 per visit. Okay, so that's the cost of seeing any dental patient within a health center. Then you got limited staff, operatories, and hours of operations that of course limit the capacity in each health center. The sustained costs, we need a certain productivity, and we call that maximizing the number of visits in order to make the money to basically cover that $190 per visit cost. So therefore we say the number of patients visiting is very critical. We call those encounter rates, and the number of encounters are critical to beat those costs. So what has happened due to COVID? Well, we have PPE costs and limitations. We have limited staff for many different reasons, safety reasons, furlough reasons, due to costing, and then COVID testing. Some staff have been diverted to other functions like taking temperature, meeting patients at the door. There's been a different display of the workflow and the utilization of staff that takes more time than what was in the past. So your efficiencies are hindered to accommodate safety precautions. So the number of patients you see reduce. So there's less number of patients being seen. You also have patient and staff fear increase, which case some staff decide they no longer want to work in a health center or a dental practice because of the risk, and some patients do not come in. On top of that, you have dental supply costs that have increased between $10 and $20 trying to get the per head for the PPE. So that thing you got is you got increased cost per patient visit. So that 190 no longer exists. So what does that mean? There are other things that happen in health centers. One, some of them just simply shut down. Some went to urgent care only. Then there's also the gradual return due to the availability of PPE. And this is your protective equipment. This competition with hospitals and state regulations on the PPE flow. So sometimes dental practices were not able to maintain the PPE because other priorities exceeded theirs. There's also administrative and engineering changes that occurred in order to be safe. So the expenses went up. You have safe staffing availability, which I mentioned just earlier. Your workflow interruption, slower patient turnover, and extended encounter times. Lower daily encounters, net effect, many leaders are saying, why continue dental? As you can see, this little picture on the side, it's wow, just wow. So where are we now? How has the pandemic really hit the dental programs in our country? Well, this particular study from the Dean of Record School of Dental Medicine indicated that many people are now avoiding dental appointments during the pandemic, and there is a raising awareness on the challenge to the dental system to rebound during this time. And I leave you with this last message. Of those practices that cater to the lower income populations and minority populations, they are the ones who usually are resource poor. Going into COVID, the additional cost of COVID and the additional cost of safety makes many of these practices, unfortunately, unable to continue. And so the biggest impact of practice loss will be in the communities that affect those that are low income. So you can see this is a very big fire burning. Thank you.
Thank you, Dr. Russell. And this is so important, and something I think we don't hear often are the challenges that were being faced by the safety net dental settings pre-COVID, and now the added restrictions have kind of burdened them, as we might say, disproportionately as compared to other practices. Dr. Swann, I would like you to speak as to what are some of the organizational challenges that you have faced as someone who's been practicing throughout the pandemic and someone who's been practicing in a safety net dental setting.
Yeah, well, thank you very much for allowing me to be a part of this program. And I really appreciate the comments that have been made by the previous speakers. For me, we are part of the Cambridge Health Alliance. Cambridge Health Alliance is the largest safety net center for the state of Massachusetts. We serve a population on the other side of the Charles River of about 140,000 people. We have 3,200 employees. We have 3 hospitals, 12 clinics, but only 1 oral health site. And so I want to just talk about some of the things that we're seeing actually being on the ground, serving this population in real time. One second on this slide here. Okay, so in the state of Massachusetts, they gave us about 4 phases here. The first phase was telehealth and emergency services. The second phase was caution, non-urgent and non-aerosol procedures. And the third phase that we're in now is the vigilant guided operations to ensure equitable access to care. And then the fourth phase, which we have not entered yet, which we really don't know exactly what that means, will be the new normal. So some of the disparities that we see on our patients, of course, one that is not new, but has been impacted, and that is access to care. We're also looking at the increased severity of oral pathology. Patients who have not been able to come in to receive an appliance, teeth have moved, pathology has gotten deeper and greater, and so we're starting to deal with those types of emergencies. And also the continuity of care. We realize that continuity of care is a sequence, and that most people come to the dentist oftentimes more than they see their primary care physician. So it lends itself to the oral physician model of being able to early detection and prevention. Those type things are being hampered here as well. We've only shut down for 1 week before we resumed emergency care here. But one of the big factors that was mentioned by Dr. Russell is the fear factor. And the fear factor is multidimensional. And really, it is the fear of the unknown that prevails. And of course, attitudes from staff, attitudes of patients. People are under a lot of pressure. And one of the most important components of a practice, and this is a dental clinic that's hospital-based, is the attitudes of our front desk people. They are the ones tackling the anxiety and the stress that's coming from our patients, and it's huge, and how it also impacts their mental health. Then we have staff deployment, which creates shortages in our department. We have a residency program here. We have 4 general practice residents, and all 4 of them were deployed in the spring, 2 of which were very, very reluctant about being deployed for the testing, the drive-by testing. But they also learned quite a bit about this interdisciplinary activity and really getting, developing great relationships with the medical side forming great relationships with the people on the dental side. And these employees now were finished with their program in July, have signed up and are still employed by the Cambridge Health Alliance because they were just so involved to see how oral health provider can make an impact in the general areas. And then we have the issues of logistics and scheduling. A lot of our employees are union employees needing to get their hours. How are they faring when they have to use their health benefits to activate or take care of the time that they have to be spent off, particularly around childcare. And then we have extended hours. The extended hours from 7:30 to 8:30 every day except Friday, in order to try to exercise the social distancing that's necessary, and trying to continue with the quality of care, but also looking at producing more quantity in the time that we do have with the patients. A real huge issue that just hit me this morning was the impact of COVID on childcare, which is a huge disparity. One of the statistics that was mentioned in the article that I read is that 50% of the reasons why people are not returning to their work sites has to do with childcare. So it's an interconnected nature of childcare. Everyone is involved in this. Managing health risk, coupled with the fact that people have multiple providers with their children. 33% of the caretakers or the people who are taking care of the children are from multiple providers. And what does that have to do when children often show no symptoms from COVID-19 who are being managed by elders who are in the family? Then there's meeting the needs and balancing cost. The employees that we have here are mostly impacted, are the ones that have the lowest income, the cost of childcare. And then there's the depression and the stress that's related to this, and how it's being impacted by homeschooling. Right now, our psychiatric ward, mental health, behavioral health is at capacity based on the fact that COVID has impacted the youth as well as others around stress and depression. Since we are a hospital clinic and have to follow the guidelines of Joint Commission, we pride ourselves on providing good care, but one of the reasons and components of doing that is actually having an invaluable communication system. We have town hall meetings. We have 2 huddles a day in the dental department. Our CEO comes on almost every day with a huddle. There's just tons and tons of changes that take place around COVID-19, which therefore impacts that there is a huge need of communication. And sometimes it's frustrating because things can change almost every day. But communication is one of the most valuable assets that we have here at the Cambridge Health Alliance. All of our patients that call in have to go through a telehealth appointment. Our residents conduct that in shifts. Once they come to the clinic, doors are locked. They have to be screened before those doors are open. Plexiglass shields for our people in the reception area. And that's not just for COVID. Sometimes it's just for protection because of the frustration that are in our communities. Also, controlled air pressure. We have a number of operatories that we can't use because we only have a limited amount that have controlled air pressure when we're going to be using aerosols. And then those chairs have to be spaced. They can't be one on top of one another. And then we also use procedure oral rinses and hand hygiene. And of course, people have talked about PPE, but that is mandatory, but you cannot leave your operatory with PPE. Everything stays in that operatory. So you have to go through a lot. We've been fortunate to have an ample supply. One of the unique things that we've been able to do here at Cambridge Health Alliance over the past month or so is that we are conducting our own nasal swab test within our department. So patients who are pre-screened to find out that they're going to need a procedure for aerosols will be tested here. It's the nice thing about this anterior nares test is that you don't have to go into the nostril any more than a ½ inch. 15 seconds in each nostril. And the other nice thing about it, since a lot of people are paranoid about all of this, contributing to the fear factor is that both providers or the patient can administer the test. We'll get the results back from our lab in 6 to 8 hours. So for all aerosol producing procedures, including use of the Cavitron, people have to go through this cycle and return. It means more visits, but it also means more and greater protection. We will see that patient based on a negative COVID test result in a 96-hour period. We will extend that up to 2 to 3 weeks if necessary to get them in multiple visits in order to try to expedite the needs that they have. This is just an example of the type of communication that goes on with the Cambridge Health Alliance. We get these reports on a daily basis. They show us and tell us such things as occupancy rates, who's been transferred because of whatever reason, employees that test positive, total positive versus new positive. We have information on employees that are out of work, who's been deployed. We also get information in the sidebars about our catchment area. And these are things that are telling us about our death rates, who's vented, admissions, and the drive-through rates. These are examples of what makes our organization work in terms of communication by being able to provide this type of information across the board to anyone who's interested in reading it. Thank you.
Thank you, Dr. Swann. I think you've given us a lot to think about. You've highlighted challenges, but you've also kind of highlighted successes for us, which is great. I think we really have a good sense of how the disparities may manifest due to the pandemic on the demand side, which is loss of employer-sponsored dental insurance. Financially strained employers may cut benefits, potential cuts to Medicaid programs, and also the very fact that, as everyone has mentioned, these communities have been ravaged by COVID, and many of the supply side factors that Dr. Russell and Dr. Swann mentioned, that particularly changes in safety net settings that place constraints on dental workforce, and obviously even provider-based barriers. My question really is very broad right now, is where do we go from here? What policy changes or not do we need to see going forward? Who wants to take a stab at this? Ms. Fish Parcham, do you want to answer that for us?
Well, as I said, we desperately need right now for policymakers to continue increased Medicaid reimbursement to make it possible for low-income people to get dental care through the Medicaid program. In Medicare, we're working on a more long-term goal to get seniors and people with disabilities who have Medicare dental coverage. HR 3 is an example of a bill that's been introduced about that. That's not just pandemic related, it's related to coverage always. We know that coverage does make a big difference to dental care. We also need for states to realize that people need lots of enabling services, the transportation, the help with PPE that dental clinics need to have their costs met.
I would like to take a different angle at that. One of the things that I feel is very critical, especially for our safety net system, is a different payment methodology. Right now, we're under a fee-for-service basic payment methodology in Medicaid. And I definitely agree Medicare would be a wonderful add-in, but the reimbursement methodology needs to be revisited. I'm thinking about such things as value-based care methodologies, as well as alternative payment structures. Now, why would that be a benefit? One of the things that health centers do now is struggle to receive payments based upon encounter rates. They basically have to see so many patients in order to make enough money revenue to offset expenses. Now, a situation like COVID, it brings an immediate increase in expenses and it decreases the ability to see patients in a quick fashion. That very thing totally undermines a fee-for-service type of system, because you're not going to be making the revenue you need at a time when you really need it. And for that reason, some systems will fail. So the reason I mentioned value-based payment structure is that each patient of a health center or a dental office could be paid on a per member per month basis. In other words, the money is paid up front. It's not something you earn over time. You have the money. It's already a kind of a braided system of funding. Over time, you basically just account for the value and the ability of the patient to remain healthy. It emphasizes minimal invasive care, where it won't be all surgical or high-end needs. The ideal is to get people as stable as possible and keep them there. At the end of the year, we basically get a bonus if we meet the indicators that say we have fulfilled the terms of the contract. There is some possibility of a clawback if we don't meet those health goals. What this also does is it allows us to utilize what has been really the hard work of the Dental Quality Alliance to develop quality indicators that relate outcomes with procedures, so that we know that when we do something, it actually has a benefit from the evidence base. And so those things are beginning to be developed right now. We have some early indicators we could be using today. But at the same time, the reason why this is a big advantage, because in the future, COVID will not completely go away and something else may replace it. So we've got to look at it from this perspective. We need our money up front. We need to be able to adapt whenever those changes come. And then we can work it out over the year. That's really a benefit, rather than always chasing the dollar, which is what the fee-for-service does. I just want to put that out there.
Let me just piggyback on that, Dr. Russell. And, you know, it sounds exciting. It seems like it would be an incentive for departments in oral health to meet the needs of the money that was actually put in up front. How does this compare to the accountable care organization? Because no one seems to know how oral health fits into that model.
That's a pretty good question. And I think at the same time, the methodology of the payment structure can be adapted to any of those ideas. One of the things that you see in Oregon, they've got several different combinations where they actually have an administrative wing that actually gets the money from the Oregon Health Authority, and then they distribute it to the providers based upon the various contracts that they create. So they can have different types of services, different type of, shall we say, requirements or metrics they have to meet. It doesn't have to be the same thing in every practice. So there are some examples of adaptation here that will work in any, like ACO or any other type of model.
Thank you.
I just want to add, we've been supportive of value-based payment at Families USA. A couple things related to this specifically is that it's really important to monitor disparities and in the quality measures for value-based payment to make sure that those are addressed. And it's really important to hold systems accountable for the enabling services as well as the services themselves.
I would like to add just one other additional benefit: medical dental integration. And when you start dealing with an organization that provides all services, primary care as well as dental, you can create a system that actually is basically incentivized to work together, so that all parts of the needs of the patient are met. Right now, fee-for-service broken up into its current way will not work because dentistry have its own language, medical has its own language. But we don't come up with one level of diagnostic as well as prognosis coding that can actually be interpreted by both sides. We're never going to integrate our systems, and the communication linkages and the ability to cross refer and the ability to look at patient information has to be across evenly to both sides. And I think that is why a bundled payment structure really would work well to push us in that direction.
Thank you. Thank you, everyone. We have a lot of agreement in our comments section, including Dr. Donoff, who says integrated care, yeah. So that's great. I have a lot of questions here, actually, so I just want to ask some of those. Reed Bryan asks, I'm curious if the panelists believe that dental disparities could be mitigated if greater innovation were allowed in areas like teledentistry. In our state, flexible policies around telemedicine have alleviated the decrease in access revenue to medical services. Could this be a solution to promote oral health prevention at home and alleviate further disparities? Does anyone want to take that?
I mean, I'll try to do this. So I think teledentistry, a lot of things have come out of this pandemic that are negative, and teledentistry is one of the positive things. It existed before. I mean, we've seen great examples where, like in upstate New York, for example, where where at Eastman you had dental specialists training general dentists in practices to do services on kids to prevent them from having to drive hundreds of miles for care. And then, of course, with the pandemic, what we saw was a lot of screenings and a lot of at-home instructions given by oral health professionals to patients, to parents, and so forth. So I think there's a lot of good potential for synchronous and asynchronous teledentistry moving forward. I don't know exactly what it looks like. I don't think any of us do, but I think we need to keep an open mind and look at ways that we can, as Dr. Russell said, you know, COVID might be soon over. It may not be. It may never be over. But there will be something to replace it at some point. So, you know, we got caught not being ready, and we shouldn't let this happen again. So we need to be ready to adapt and be forward thinking on things like teledentistry.
I think that brings up another case and point here is that the practice of dentistry in the past has been basically a surgical model where we chase disease. The future would have to be to prevent the disease from starting. It has to be to catch it early as possible and at least the least amount of intervention possible. With that in mind, technologies like telehealth really helps, because if you can guide the patients through a good regimen of self-care, you have very little disease processes you have to deal with when you do see them in the clinic. And you can delay some of those visits because they are maintaining a good oral health environment. So you can focus a lot of your resources on those that truly need care. So the ideal going forward is we've got to go upstream. We can't keep waiting downstream until the disease process is full blown and where we're spending millions of dollars trying to basically treat symptoms rather than dealing with the disease that led to the symptoms to start. This is where the rubber hits the road. This is where medicine and oral health care become one.
Right. And just going back to some points that were made earlier, particularly by Dr. Swann, looking at some of the social determinants of health, I think this is a real call to action for us to begin to think about these integrative preventive models that look at whole person health, that include not only medical and dental care, but the social determinants and things like childcare and barriers that currently preclude those who suffer from disparities from accessing the care they need. There's that financial model and all of those issues that go into access and the social determinants. And we need to be thinking as we go forward with some of these models like the ACOs and others, how do we begin to bring some of those other elements into the care packages that can eliminate the disparities that we're seeing worsened right now by COVID?
I think to add to that, Jane, is that we are also looking at how we are taking care of our special needs populations, our elder services, as well as the people that really here, we have a high level of people who have mental illness, and telehealth may or may not work as well for them if we're not able to reach their caregivers. So it's multifaceted in that regard.
Dr. Swann, you bring up a great point. We haven't really talked about elders in long-term care facilities. And I'm just wondering if anyone can comment on how COVID, what we can do in terms of oral health for those in long-term care facilities. We've been hearing a lot about the impact of COVID on the facilities, but not about oral health for those in long-term care.
That's a very interesting topic. We in Iowa have been trying to expand our oral health services into long-term care centers. One of the problems that you have is the fact is with COVID, a lot of those centers shut down. There were no outside visitors basically allowed to go inside to keep those elders safe. That made oral health in the practical sense very hard. But at the same time, it opened up the idea of trying to maintain their health as they enter into these facilities. The problem is many of these individuals were insured and had health care and dental care prior to going into a long-term arrangement. It's during their tenure in the long-term arrangement that everything breaks down because there isn't the regular access to care that they had outside. Now, if we use telehealth in an effective manner, we would be able to work with their caregivers in those centers and try to keep their health high as they enter into the center and keep that work that's been done all of those years in good shape. And that can be done by, for example, having a registered dental hygienist to actually be on staff in every long-term care center. That would be a very good way to do it. To extend the utilization of extenders that can work in facilities at a much lower cost than, for example, trying to have a dentist come in and do invasive care in order to rehabilitate people as they get deeper into it. So that's just one solution. We have not tapped the full ability of our workforce so that we can distribute them into the places where they need to be. That's something we haven't even done before COVID. And this is all he's saying now. We might need to start utilizing those methods, maybe new workers like dental therapists or others who can provide some intermediary work just to keep people out of harm's way. I think now is the time to think out the box.
So the hour has actually really flown by, and this has been such a rich discussion. I actually just wanted to end this webinar by quoting the Surgeon General from the oral health seminar at HSTM early this month, where he said, we can't have health equity without oral health equity, and we can't have an economically successful country if we have an unhealthy country. And I think that's really something that we need to take with us from this webinar. On behalf of the HSTM initiative to integrate oral health in medicine, I want to thank our panelists for sharing their expertise with us and for joining us today in this very rich and very timely discussion. Thank you so much, Dean Barrow, as always. Also, thank you to all the participants for joining us today. Have a good day.
Thank you.
Thanks, everyone. Bye-bye.
Thank you.
Thank you. Bye-bye.